and pediatric imaging with our esteemed and distinguished guests attending and the chairpersons from the pediatric department of University and distinguished speakers. We start with the first talk by Dr. Khaled Fotouh. The title of his talk is the Imaging of Acute Neonatal Encephalopathy. تفضل.
شكرا دكتورة هنا. برحب بالسادة الحضور، برحب بضيوفنا باسم الأطفال دكتورة ميرفت شفيق من قصر الأستاذ أشعة الأطفال. برحب بالسادة الحضور كلهم والزملاء. الحقيقة الموضوع Neonatal Encephalopathy imaging approach it's a very big issue to be discussed in 20 minutes. ولذلك أنا هركز على جزء معين من Neonatal Encephalopathy اللي معظمنا غالبا بيتجنب ان هو يخش فيه، حتى احنا لسه we are building our experience in our hospital. فاول حاجه ايه هو Neonatal Encephalopathy؟ Acute Neonatal Encephalopathy what it means? It's an acute disturbance of neurological function in the earliest days of life in term infants, usually manifested by difficulty with initiating and maintaining respiration, depression of tone and reflexes, subnormal level of consciousness, and often seizures. Neonatal encephalopathy is approximately 3.5 to 6 per 1,000 live births, usually full-term infants. The potential etiologies for neonatal encephalopathy, hypoxic ischemic encephalopathy, which is the most common. I'm not going to talk about the most common, which I think everybody knows now. Metabolic disease, infection, and some drug toxicity. The requirement for investigation to exclude these possibilities will depend on the presentation, history, and clinical features of the individual cases. Metabolic disorder, which the topic I'm going to speak about it now. Metabolic disorder of brain in neonatal or early infantile period are usually associated with acute and severe illness. Usually the presentation in neonatal period or early days of life reflects a severe enzymatic defect or severe inborn error of metabolism. And that's why usually we see different forms of the neurometabolic disorders, neonatal form, infantile form in a child. It's according to the degree of enzymatic defects and the function of the enzymes, how much it's affected. Usually this affection doesn't appear in fetal life because usually the placenta removes the toxins which affect the brain, but after delivery the body has to deal with these toxins. Early diagnosis is very important both to prompt treatment to prevent death or serious sequelae and also for genetic counseling. All of us knows how these problems make a social and economic impact on the families and the country. Diagnosis is challenging because many findings overlap and may mimic those of more common neonatal conditions like hypoxic ischemic injury and infection. Usually we use ultrasound. It's the initial handy tool we can use in incubators, in neonatal ICU. MRI, including diffusion-weighted images and MR spectroscopy, is a modality of choice that may help diagnose metabolic disorders and assess response for treatment. If one of these rare disorders is suspected, the appropriate biochemical test or analysis of specific gene should be performed to confirm the diagnosis. And this is our rule to say this disease in which category, so we can narrow the differential diagnosis and help them not to expend a lot of money in investigation just to know where is the defect. This is a very big issue and very time consumable and very expensive to do it. Our role in radiology is to narrow the differential diagnosis and say this is a neurometabolic disorder for like it's amino acids metabolism disorder or something like that. Why it is metabolic cause and not hypoxic ischemic injury? Usually we deal every day with the hypoxic ischemic injuries. Ain Shams University hospitals as a big tertiary hospitals, we on daily basis we see hypoxic ischemic injuries, but why should I think this is a metabolic cause and not an hypoxic ischemic cause or infection? Delay onset of symptoms. Usually if the symptoms delayed after the first day, second day, first week, usually I have to think about this is a metabolic disorder and not an hypoxic ischemic injury. No clear history of perinatal asphyxia, which we have to insist to know the after school was abnormal or normal. Is there any difficulty in labor or not? And there is a history of perinatal asphyxia or fetal distress or not. Also the involvement of the non-myelinated white matter. Usually the myelination, okay, for myelination to occur it needs a lot of energy. These areas of brain is metabolically active. It will be affected more if there is a hypoxia or ischemia. But if I found non-myelinated white matter affected, this is a metabolic disorder and not a hypoxic ischemic injury. Imaging of acute neonatal encephalopathy, ultrasound, it's handy, cheap. I can do serial everyday testing for this neonates, but it has some limitations. It's less sensitive for detection of early and subtle lesions, and often non-specific. I can, with ultrasound, concentrate on the deep gray nuclei on the ventricles, but it's hardly seen to see the pattern in the cortex of the brain. So ultrasound lacks the pattern of brain involvement. Computed tomography, limited poor contrast resolution because the increased water content of the brain makes the differentiation between the gray and white matter very difficult. So that plus the radiation exposure, it's not ethically even, unless this is a critical patient or I don't have MRI to do CT brain in such young neonates. MRI is a modality of a choice, but it has some limitations. But with MRI, I can characterize the pattern. I can see the involvement which have been described in several metabolic brain disorders. White matter is primarily affected in maple syrup urine disease, non-ketotic hyperglycemia, deep gray matter lesions in organic acidemia, and both gray and white matter usually in primary lactate acidosis or mitochondrial disorders, which is communal. Here is the differential diagnosis with the hypoxic ischemic injury. Also usage of the advanced MRI imaging technique like diffusion weighted images, which is very sensitive for early parenchymal lesion, help differentiate different types of edema. It is vasogenic like in urea cycle defect or cytotoxic edema in neonatal maple syrup urine disease and non-ketotic hyperglycemia. Also the calculated apparent diffusion coefficient from the diffusion weighted images can help follow up and early detection of these injuries. MR spectroscopy may be helpful not only for diagnosis but also for assessing response to treatment in patients with metabolic disorders. Some abnormalities may help as prolonged lactate in mitochondrial and primary lactate acidosis, glycine, non-ketotic hyperglycemia, and branched amino acids in maple syrup urine disease. This is a suggested protocol. It takes about 17 minutes to 22 minutes. I'm going to do more than one MR spectroscopic voxel, diffusion weighted images, T1 weighted images axial, T2 weighted images axial, T2 star weighted image, and MR spectroscopy. This protocol takes about 17 minutes to optimize the signal to noise ratio and tissue contrast, because we have also here the same problem. The brain water content is very high, and I have to, so I am going to change the parameters of adult to be adapted for this neonates. Acute metabolic disease in newborn, metabolic disease which presents in young neonates. Organic acid disorders, I'm going to talk about the propionic acidemia and methylmalonic acidemia as examples. Amino acids metabolism, urea cycle defect, and maple syrup urine disease, non-ketotic hyperglycemia. As an example, primary lactic acidosis, Leigh's disease, fatty acids, glutaric aciduria type 2, and some others metabolic disorders like Krabbe, Zellweger, and galactosemia. Organic acid disorders, propionic and methylmalonic acidemia, both are autosomal recessive disorders. The manifestation usually is ketoacidosis, excretion of this propionic acid and methylmalonic acids in urine. The neonate is usually lethargic, tachypnic because of the metabolic acidosis. There is vomiting, seizure, coma, and death if I am not going to interfere. Ultrasound and CT diffuse brain edema, non-specific. MR imaging, edematous swelling with hyperintensis in basal ganglia, midbrain, dentate nuclei, and cerebral cortex should pay my attention for such organic acid disorders. MR spectroscopy, non-specific, but I can see a glutamate peak at 3.8. And follow-up becomes, the brain becomes atrophic with delayed myelination and typical bilateral globus pallidus lesions in methylmalonic acidemia. This is the normal coronal ultrasound brain, and this image with edema. I can see the attenuated ventricles here, and I can see the echogenicity, increased echogenicity of both thalami and basal ganglia in comparison to normal. Diffuse brain edema. Here is the CT. Usually we used in old days to diagnose this as a hypoxic ischemic injury, infarction, bilateral occlusion of carotid arteries, white cerebellum sign, diffuse brain edema, effacement of sulci and attenuated ventricles. MRI, this is an axial T2, bilateral corpus striatum, caudate and lentiform nuclei edema, and cerebral peduncles abnormal signal in T2. And when we did MR spectroscopy, it's non-specific but low MEAA and this glutamine peak at 3.8. It should pay my attention that this is maybe propionic organic acid disorder. Amino acid metabolism, urea cycle defect. It's also autosomal recessive, lead to accumulation of ammonia and other nitrogen component, which is directly toxic to the brain parenchyma and indirectly promotes synthesis of glutamate, which lead to encephalopathy. This glutamate I am going to detect with MR spectroscopy. There are many subcategories for this amino acids metabolism according to the defect and which amino acid is affected. Acute encephalopathy may be aggravated by high protein intake. That's why I have to mention from the start this may be a urea cycle defect. Please restrict protein in diet. Neonatal onset disease are usually associated with more severe disturbance of enzymatic function, as I said before. Urea cycle defect, ultrasound, brain edema. If I did non-enhanced CT, attenuation in deep gray nuclei, which I mean thalami and basal ganglia, white matter cortex is swollen, effaced. Best diagnostic clue, neonatal presentation with basal ganglia and cortical diffusion restriction. Location in neonates, deep gray nuclei and depth of sulci. At the depth of the sulci and subcortical U fibers, parietal and insular distribution more than temporal cortex. The non-myelinated white matter is more severely affected than the myelinated one, and posterior fossa usually spared. MR spectroscopy, I'm going to search about the glutamine and glutamate. This is axial diffusion weighted images, shows the diffusion restriction at the depth of the sulci, the subcortical U fiber. Here the internuclear edema, bilateral and diffusion weighted images between the lentiform and globus pallidus, between the lentiform and the caudate. This is the axial T2, shows this edema, and this is the MR spectroscopy showing the glutamate peak just beside the NEAA and the lactate doublet peak at 1.3. The second disease is the marble syrup urine disease, also an autosomal recessive disorder. The affected neonate usually present with poor feeding, vomiting, seizure, and coma, hypoglycemia, and characteristic odor of maple syrup, which is the burnt sugar. The smell of the burnt, odor of the burnt sugar. MR imaging, generalized edema of the brain with restricted diffusion in the myelinated white matter. Here is the affection occurs in the myelinated white matter. And if I did MR spectroscopy, I can see a peak of branched amino acids at 0.9 to 1 ppm. This is the ultrasound, diffuse brain edema, very apparent in salami, and this is the CT. I can see a differentiation. This differentiation is abnormal. Usually there is no differentiation in neonates between the gray and white matter. And when we did MRI, this diffusion-weighted images shows diffusion restriction in all myelinated white matter. The myelinated white matter is the only affected. This is very characteristic. And when we did MR spectroscopy, this abnormal peak at 0.91, this is the branched amino acids. Non-ketotic hyperglycemia, also an autosomal recessive disorder. The MRI usually shows white matter edema and delayed myelination, and usually there is a diffusion restriction in frontal cortex, white matter, and corticospinal tract. And when we did MR spectroscopy, we can see glycine peak at 3.56. This is axial T1. Usually at birth, full term, we should see the myelinated posterior limb of internal capsule. Here is missing myelination. Missing myelination of the posterior limb of internal capsule, and diffusion shows the diffusion restriction in the posterior limb of the internal capsule. Some other associated anomalies like hypoplastic corpus callosum, this is late finding, the mild diffusion in the cerebellar white matter and central tegmental tract in posterior brain stem. When we did MR spectroscopy, this peak of glycine appeared at 3.6 on the scale. At this site, usually the myoinositol appears at this side, but usually in short echo MR spectroscopy. We have to do long echo MR spectroscopy to detect the glycine at the same site of the myoinositol. Primary lactic acidosis, pyruvate dehydrogenase deficiency, or what we know Lay's disease, usually hypotonic ataxic, and they have ophthalmoplegia with difficulty in swallowing. MR, usually edema involving non-myelinated white matter, typically high signal in deep gray matter, striatum, caudate, lentiform, and cerebellum, very aqueductal white matter and cerebellar peduncles on T2 weighted image. MR spectroscopy usually shows a prolonged lactate doublet peak at 1.3. This is the ultrasound, coronal, bilateral edema in basal ganglia, axial T2 weighted images, bilateral edema in salami and basal ganglia. And here is the diffusion restriction in this ADC map, this dark signal in the caudate, anterior lentiform, and bilateral thalamic. And here MR spectroscopy shows a big lactate doublet peak at MR spectroscopy at 1.3 ppm. Fatty acid oxidation disorder, glutamic aciduria type 2. Usually they have a problem with the long chain fatty acids. MR spectroscopy, bilateral striatal affection, peritrigonal white matter, and splenia of the corpus callosum. MR spectroscopy usually shows increased choline-creatine ratio, which is a sign of dysmyelination. Here is the axial T2, bilateral basal ganglia abnormal signal, and peritrigonal, which shows diffusion restriction involving the splenium and peritrigonal area. Other metabolic disorders like Zellweger syndrome, also it's an autosomal recessive, affected infant presented with poor feeding, prolonged jaundice. Usually they have hypomyelination and cortical malformation. Here is the axial T2 weighted images, abnormal signal in white matter, delayed myelination, and the paucity of cortical sulci brachygyria. And ultrasound shows the germinolatic cyst in the caudothalamic groove in the coronal transcranial or transfontanellar ultrasound. Other metabolic causes other than inborn error of metabolism, hypoglycemia, usually present in first 3 days of life with seizure, apnea, irritability, and hypotonia. Usually we have a bilateral occipital in this sequence, occipital, parietal, frontal, according to the severity, bright diffusion weighted image restriction in neonates with seizure. Basal ganglia, salami, brainstem involvement can occur, but most most commonly, white matter injury is common in periventricular and premature. Usually MRIS is normal, maybe it shows a small lactate peak, but the top differential diagnosis is hypoxic ischemic injury and inborn error of metabolism. Here is a CT. This is a bilateral symmetrical hypodemesis and frontal as well. Diffusion restriction involving the cortex, more posterior, and this is the T2 axillated images, the brain edema and bilateral occipital abnormal signals. The last one, connectors, hyperbilirubinemia, encephalopathy due to unconjugated bilirubin crossing premature blood-brain barrier. Usually it comes with hypotonia, post-suckling, and high pitch, and we have a history of jaundice. Incidence increase with early discharge if I'm not going to treat this baby properly and the bilirubin is still rising. There is more chance to be affected and increase in breast fit. Deafness or abnormal auditory process, this is the most common sequelae. Chorioacidosis and gaze abnormality, this is late sequelae. MRI usually shows increased signal in T1 weighted images, which is the bright signal in T1 weighted images in globus pallidus and substantia nigra and hippocampi subthalamic nuclei. Here is the T1 weighted images, abnormal bright signal, T1 shortening in the salami, globus pallidus, subthalamic nuclei, and substantia nigra. And this is the late sequelae, the corpus, the globus pallidus affection. It's difficult. The difficulties we face in neonatal imaging in MR. Performing MR study in neonates demands particular care with regard patient transport, especially if he's on a ventilator. We have to have an incubator with ventilator to transfer. Monitoring of the vital signs during the exam. I said the exam will take from 17 to 22 minutes. Optimization of acquisition technique. We have to be aware and have an experience in choosing the appropriate coil, sequence, and protocol to apply. Accurate interpretation of the findings depend on familiarity, needs experience with the normal appearance of the myelination, cell migration, sulcation at various gestational age. Careful review of clinical history and information that may help identify the cause of injury. Although non-specific brain edema and lack of myelination are common imaging findings in neurometabolic brain disorder, several specific patterns of the brain involvement may be identified. Here, this is the MRI compatible incubator. We have in for 2 to 3 days in week in Demerdash. This is the only one in Africa and the second one in Middle East. We have MRI compatible incubator with MRI compatible ventilator. Take home message, hypoxic ischemic injury is the most common cause of encephalopathy in newborn. Most inborn error of metabolism present in neonates have potentially severe outcome. MR imaging is a powerful technique for diagnostic evaluation of neonatal encephalopathy. Diffusion weighted images and MRIs provide functional information and improve the imaging diagnosis. The diagnostic approach should include comprehensive MR imaging as well as assessment of clinical manifestation and proper screening test for adequate emergency treatment. Early detection and accurate diagnosis allows the most appropriate therapeutic option to be identified and adequate counseling to be provided to ameliorate the bad outcomes and the bad socio-economic impact. Thank you.
First of all, I'd like to welcome Professor of Radiology at Radiology. And I'd like to invite her up here to the stage. So there is a little mind.
نفسي اعرف يعني الريليشن بتاع الالتراساوند في القصه دي. انا يعني ما بيتهيأليش ان احنا بنشتغل ترانسكرينيال في القصه دي خالص. فانا شايفه هنا يعني انت الدايجنوستس بتاعك كله يعني بيعتمد على السايت اوف افكشن.
ايوه
بس كده.
لا في باتل للانفولفمنت. انا معايا دي جرين بس افكتد، معايا سيرفيلا افكشن، معايا كورتيكال افكشن، معايا وايت ماتر بس هي اللي افكتد، وفي جرين وجرين سليمه ولا كومباين باتل. الباتل ده يبقى بولي يعني ديفايد باي ultrasound. But at least in ultrasound I can say there's a diffuse brain edema do MR.
طيب يعني والدكتور يعني احنا الهيبوكسيك اكتيمال انسس بيفرق معانا جدا الدكتور. يعني ممكن ما يبانش عندي في الترانسكرينيال التراساوند، لكن الدكتور بيفرق، بيديني حتى حاجه ان في يعني something wrong going on. بيدي انديكيتيف كده. فهل يعني انا في الميتابوليك ديزيز بيبقى عندي يعني افكشن في الدكتور ان هو يديني انديكيشن لحاجه حتى لو انا التوجيز بالنسبه لي مش فارق؟
هو نفس الافكتس. الدكتور افكشن بيحصل نتيجه الاديمه. انا عندي برضه في اليوم ده اديمه، فهنا الالتراساوند هيقف مش هيقول لي الفرق ما بين.
Any other questions?
دكتور خالد، انا احييك فعلا على المحاضره القيمه دي حقيقي يعني. وده يعني يبين لنا الفرق في الاجيال. يعني احنا الانسفالوباثي دي عملنا مع زمان، يعني على زمان المحاضرات مش ابدا يعني. طبعا ده بروجرس اساسا للام ار، لان هو حضرتك زي ما قلت ان الالتراساوند تقريبا ولا سي تي ليهم رول. حتى الام ار مش لوحده، يعني لازم مع الكلينيكال والنيوموداليتيز كمان في الام ار، يعني كله مع بعضه ممكن حتى نوصل للتشخيص. وخصوصا ان بقى كتير من الحالات ليهم فيري سبيسيفيك متكرره، يعني فعلا ممكن نقدر نشخصهم بالاشعه جنب الكلينيكال. يعني شكرا ليك.
Any other questions?